Hello students, this is Dr. Turpin. I'm going to finish up our PowerPoint for today and just review the ending components related to the last neuromuscular disease, and that's myasthenia gravis. It is a motor disorder in which you see a lot of fluctuating localized skeletal muscle weakness and fatigue. As with some of the others, it is an acquired autoimmune disease, but it affects the neurojunctional transmission. And so there are three different types. We're going to mostly just deal with the first type, which is considered an anti-acetylcholine receptor type, serotype, and antibodies in this autoimmune disease against the receptor sites bind with those and just destroy the ability of the receptor sites to connect with acetylcholine that is fluctuating. So when at the neuromuscular junction, if there's not the ability at the receptor sites to take up acetylcholine, you have a lack of nerve impulse transmission. And this kind of pretty much says the same thing that I just said. So you just have to kind of think about this is more of a defect related to the actual neurotransmitter in terms of its sometimes availability, but also ability to kind of be utilized because of this receptors being a problem. Symptoms that you see in about 2/3 of the patient, and usually within the first 2 years of onset, are ocular symptoms. Ptosis, which is drooping eyelids, can happen either on one side or bilateral. Patients may also exhibit diplopia or double vision, and that comes from muscle weakness of the extraocular muscles. And with any of the ocular symptoms, they really worsen whenever a person has had been doing some type of activity that uses their eye muscles a lot. You'll notice it much worse during that time. They also exhibit bulbar symptoms, and so this is one of the key things that is even more prevalent maybe with this disease than some other diseases, is this condition of a weakened throat muscle where they have an altered voice, they can have nasal regurgitation, they can have choking spells, and they can have significant difficulty swallowing or chewing, and which leads to potential aspiration. They need to all be on aspiration precautions, and because of the throat, the airway region, and the aspiration potential, that can also lead to respiratory collapse, which is a high risk for that patient. So this is not somebody that, until you really evaluated that, you would want somebody feeding or allowing a family member necessarily to feed until you were really comfortable that they understood that process. Myasthenia gravis is also associated with increased incidences of rheumatoid arthritis, lupus, and thyrotoxicosis. And we will be in the next section that all the things that fall under immunology and endocrinology will be touching on the next section in our course, so you'll hear more about those then. In terms of testing or trying to determine if somebody has myasthenia gravis or not, this hydrophonium or tensilon testing is what it's normally called by most people, is the way to determine that. This drug tensilon can be given IV push and within 30 to 60 seconds, for most patients, you'll see a drastic improvement in their muscle functioning. It is short-lived because it has a short half-life, so you only tend to see the improvement for about 4 to 5 minutes. And then the other key thing to know is sometimes patients that have too much of some of their myasthenia gravis meds may have some of the same symptoms, and you'll see that in later slides. So if you give this drug and you're trying to decide if they've got myasthenia gravis or they're in a cholinergic crisis, when you're giving them more of this, it will has the potential to cause bradycardia, so you never want to do this test without having IV atropine available. Now, I put you 2 different clips of videos. The first one is a really good one in terms of showing you like the immediate effects of this, and I'll try to play this for you where you can see it in the screen. You can certainly watch it on your own again if you would like. The second YouTube that's listed there is got more of a patient example that shows a little bit of how this test would affect a patient, but I think you see the effects of it really well in this first video clip I'd like to show you. If you'll just bear with me for a second here, I want to try to move this over the screen so we can play it. So in this example, I'm going to back it up here. This is a dog that has this disorder, and he, has some really erratic, fluctuating impulse conduction, and it's affecting his muscle function and strength terribly. The attendants here are going to give him some IV push Tensilon, followed by some saline, I think, to get it on up in his system through the saline lock there in his little paw arm. I guess they don't wear gloves or know how to not cap needles, so avoid that practice. But now you can see how just it doesn't take long at all, and suddenly the dog here is able to have that transmission improve drastically, and so we know that this dog is suffering from that condition. So just to continue here, we'll move back over here and moving right along. Just know that when a patient responds in that manner, that is considered a positive Tensilon test. So the drugs that are given for myasthenia gravis have sort of a similar kind of function as you saw with that. They're considered anticholinesterase drugs or anti-myasthenics. 2 of the most common ones are listed there. The one I've seen given lots of times is Mestinon. But the way these work is they prevent the decrease of acetylcholine that's circulating, that is being affected by the enzyme that's listed there. And so when you kind of take out the enzyme that's destroying the acetylcholine that's circulating, you have more of it there to kind of hit what receptor sites are there. And so it requires a constant, pretty set administration of these meds, throughout the day at regular, intervals as they're ordered, and at the correct dosages for the patient that works for them. And that has implications too, because you think about somebody who is, say they're having nausea or vomiting from some other issue, or let's say they're MPO for surgery. That is something that has to be addressed, and if you notice a patient that's on one of these myasthenia gravis meds that needs continual use to keep their musculoskeletal function working properly, or neuromuscular working properly, you have to call the doctor, make sure that they change them over to an IV version of this drug while they're MPO. Another thing to note about these drugs is they must be administered with food. The most common side effect for them is stomach pain, nausea, vomiting, and you don't really want to mix those kind of side effects in with already some choking potential and aspiration precautions as well. And then last of all, you kind of want to pay attention to what drugs that they are on, because there are a few that cause drug interactions. In terms of nursing management of myasthenia gravis, some of the same things are done. Immunosuppressive drugs are given, so they can be a little bit more high risk for infection. They can have plasmapheresis to remove circulating antibodies, so there's less destruction of the receptor sites. Because of the issues with swallowing and aspiration and in the throat area, they may need some respiratory support. They can do nerve stimulation and electromyography repetitively to assist with some function. And the biggest thing from a nursing standpoint, I think, is promoting them to do as much as they can on their own so that they maintain their independence as long as they can. Teaching them really, again, the consistency of the medications and doing that well. Assisting with communication, or having a communication board sometimes may be a problem because of the way their speech may be affected. And then nutritional support, getting safe swallowing studies periodically to see if there's any worsening problems with that. Some of them may not be able to eat normally because of the problems and may have to have alternate ways of nutritional support, whether that be like a gastrostomy tube. If they're having ocular issues, they probably need to have eye protection that kind of helps those eyes not have worse problems. And for extreme cases, if they're going to do surgery, they can do a thymectomy to remove the thymus gland, and that can help with the condition. We'll learn more about that when we get into endocrine a little bit. It's important to distinguish between myasthenia crisis and cholinergic crisis. Myasthenia crisis is when they have a severe deficit of acetylcholine, so it's like kind of the worst case scenario for the disease itself, where they have severe muscle weakness, and especially in the throat and the respiratory region. They may have trouble controlling secretions and saliva. Mucus can get caught up in the upper respiratory tree, and they can go into respiratory arrest. And just as you saw in the video, the treatment is to give them some Tensilon quickly, IV, to kind of solve that problem. So, but again, you will see in this next slide that cholinergic crisis, it happens when there is too much drug therapy, and now they're kind of toxic. So they have all the same symptoms almost. So you still do the Tensilon because you don't know which is which until you do that. If they have a react to the Tensilon, then you know you're okay. But if they don't, then you have again this issue where you may have bradycardia, and you have to be prepared for that. Health teaching just goes over a lot of the other issues that we've already covered.